right, we'll do our last case here. I think this is a great place to stop on this last case because
it'll be fun collaboration for sure.
These are always challenging. And this doctor really took a very interesting approach. And it's something that we all try to do, right? We learn all these different techniques and try to incorporate them into the way that we practice. So this was a case, clearly there was a very severe defect, mostly in the horizontal dimension anteriorly. And for whatever reason, this doctor really wanted to save 6 and 11, almost like an insurance policy. And we can argue that all day long. But he was very cute and he treated the endo defects, the endo abscesses, and he did a 2 implant placement, immediate implant placement with PET, which is something that, I think on these root canal teeth definitely takes some guts. But really the question that they were asking is, how do we treat this anterior defect? And you can see here, what's nice about it is it's not a vertical defect. It's a horizontal defect. And if you look, it almost looks like it's very concave, really within the housing of the bone. So there's certainly a lot of different approaches here. I think 3 of us can definitely think of, probably 7 or 8 different materials and techniques that we could potentially use here. But, we all kind of have our own experiences and what works well in our hands. And I'll tell you, there was a time when, like I said earlier, I was doing resorbable and sutures for everything. And this is one of those cases where I thought, hey, why not? I have a nice concavity. And that's exactly what I did. I did a rib roast. I actually used, collagen membranes. This is Ossix Plus. We really overbuilt it. If you look at the scan at the bottom, I thought I was doing really, really well, at least at the sites that were planned for implants. And soft tissue healed beautifully, opened it up. And I don't even have a picture from the initial opening because I was so disappointed in what the bone looked like. And then I placed the implants and I mustered up the courage and I got my camera. I took a photo. And if you look back and you kind of compare, okay, I did okay at some of the sites. I mean, I did fill in some of that concavity, but these are the cases that haunt me. Like, why did this case not regenerate where most of them do? And I really think it comes down to not only patients, their own skeletal envelope, but also the lip pressure. And I think in the maxillary anterior is really huge, which is why for me, that case that Israel showed with the large vertical defect, I still think, the titanium reinforcement is not a bad way to go because you need something to resist the lip pressure. And so nothing wrong with not getting everything you needed, right? I went back and I added a little bit more graft. And so we can certainly be successful there. But in the anterior, I'm really more prone now to using some sort of stability device like a tack or a screw. And similar to how Israel used the DPTFE, I'll do the sausage technique. And one of the most challenging things of these is that large curvature. How do we manage that large curvature? So one of the things I learned from Istvan Urban is why don't you just turn it into 2 easy surgeries, right? So rather than trying to make something that a membrane that will reach all the way across and have to get everything stable at a one time and feeling like bone graft is just kind of, falling off the sides here, I treat it as 2 completely separate defects. And this is an approach that saved me numerous times because this turns a really challenging defect into 2 easy sausages, right? So I just like Israel, I tacked the both membranes, actually using fixation screws probably, and the implant handpiece adapter on the palatal, pack the bone, fold it over that buccal-occlusal line angle, and then can get it really nice and taut. And you can see, we can certainly regenerate these types of defects. But I think by using the tacks and the screws, I think I can pack more bone and I can get it a little bit more taut. And so there's not any one technique, even though we are fans of using resorbable materials, resorbable sutures, getting away from using mallets. That's something we do use in our courses is teaching all of these different techniques. So I think that's something that we all always have to keep in mind. There's not one technique for any defect. Really, there's a lot of different approaches. And I'd like to ask you guys, how often are you guys using Curry? Because I know you guys have both sort of dipped your toes and you started doing cases. Is this something that you're doing on a regular basis, or is it maybe, once in a blue moon?
I'll just speak because Brandy is muted over there. But I honestly, I've only done one Curry case, and it was it 2? Or either 1 or 2. First one I ever did was an incredibly challenging case, and it was missing 7 and 8, vertical, horizontal, everything missing, and turned out really well. But man, that was a beast of a procedure, and Yeah, it's just not something that I do a ton of, or much at all. But I'm going to be doing more. I think it's very cool. I think there's definitely a place for it, and started to actually with Curry, started to look at taking Zastro's course and learning more of it. And I see it in the future. It's going to
Yeah, it's certainly enticing. I think also, once you get really good at mastering periosteal release, and using hardware, then it actually, it looks more challenging, but in a lot of ways, it's actually, a lot easier, right? And that's, I think, why a lot of people like it, because you're not having to deal with a membrane or collagen. I find that, I just think it's being overused a little bit now. I see so many horizontal defects. I think that could be solved so easily with, resorbable materials.
1000%.
Yeah, a little allograft, a little membrane, and you're done. And taking a big block of bone and cutting it, it's a little overkill for sure.
Well, I think
a minor horizontal defect.
Yeah, the intimidation factor is the harvesting site, with getting, autogenous graft, a block graft. I think people just aren't accustomed to elevating large flaps in the mandible and dealing with the inferior alveolar nerve and getting that large piece of bone that you need for Corey plates. Obviously, Israel and I have not mastered this technique. We're actually going to be in Germany in September to go to Zastro's course. I don't know. Israel, have you signed up for that yet? Probably not.
No, have you?
No, but anyway, I'm going with a bunch of other guys here from the United States, but yeah, there's so much overutilization of autogenous bone when you guys have absolutely mastered GBR, with Allograft, and with the materials that we have is completely successful, super exciting, and the learning curve is there, and I think that attending your guys' course and being a part of it now, and even in April, it's an amazing opportunity to learn something that you can incorporate literally from day one. So, yeah, I mean, you guys have revolutionized, in terms of building bone in a fairly easier way. But I love the way you approach that, Matt, with utilizing that anterior segment with basically treating it as two defects, because the anterior nasal spine, is basically set yourself up to go, okay, I'm going to go right and left and build up that bone the way that you guys did. And I think it's completely successful.
I've always sort of imagined a way to trim the membrane so you can get it around the curve, but I'm just not really good with paper mache or whatever that craft is. So that's definitely a good way to go.
That's the way I do it too, is just you treat it as two separate defects, and that's the most successful way. But I love those nice anterior defects, almost like a bowl that's just waiting to be augmented. So as long as you have the height, I think horizontal defects, I mean, that's so predictable. Building width is so much easier than building height. And you guys have mastered it 100%.
Looking at some of the cases we showed tonight as we wrap up here, it's all the same technique, no matter what materials you're using. For the most part, it's the same principle, same technique. One thing we didn't talk a lot about tonight, but for any ridge aug, we're always using autogenous bone, using minimally invasive ways to harvest autogenous bone, and then the periosteal release. And so gaining your confidence in these horizontal ridge augmentation cases is so important, so that when you do tackle the larger vertical cases, you have a way to go. And I have no problem trying to use resorbable for these smaller vertical defects. But again, what you said earlier, I'm never going to tell the patient that they don't need a second graft, because you just don't know what you're going to get. You don't know what you're going to achieve on that first round.
Always prep them. And you showed there, you do GBR a million times a day and have amazing success, but there are times when a little part of it doesn't turn out as well, and always be ready to throw some more in there. That's not a failure. That's okay.